from Sarasota Memorial and the Deb Kavanaugh Multimedia Studio, this is HealthCast, a healthy dose of information from experts you can trust.
Hi, everybody. Welcome to HealthCast. I'm Allison Gottermeyer. Thank you so much for joining us today as we talk about minimally invasive cardiac surgery. Our guest today is Dr. Jonathan Hofberger, Chief of Cardiovascular Surgery here at Sarasota Memorial and Medical Director of Minimally Invasive Cardiac Surgery here. Dr. Hofberger, thank you so much for joining us.
Thanks for having me.
Can you start by talking a bit about the development of the minimally invasive cardiac surgery program here at SMH?
Yeah, so when I came to Sarasota Memorial in 2010, we started the minimally invasive program. There had been other iterations of this through the years, trying with the robot, things like that. But when I came, there was the minimally invasive program was really in its infancy. And I brought the right thoracotomy approach here. We felt that that was a more reproducible and better approach than the robot. And we've developed that over time. I think our first year we did about 25 cases. We're doing in excess of 150 a year now.
And that all fits into the heart team approach. So can you talk a little bit about what that is and how it's used to ensure that patients here have the best possible outcomes?
Yeah, so years ago, cardiology was almost like a separate silo than cardiac surgery. And cardiology is the medical management of the patient, of the heart. And it's done with, the cardiologists do that either with medications or with stenting and things like that. Anything more than that would really require a surgeon. But over the last decade or so, there's been a movement in cardiology to be able to do some of these valve procedures less invasive, like through the groin, through an artery or through a vein. So they started doing some of these procedures, and the outcomes have been excellent. And what it has done is it's kind of brought the gap closer together between surgery and cardiology. And so with that, we've kind of felt that it was important that the patients all get the right procedure and that we're all in agreement that that's the right procedure. So we developed this heart team approach where we get the cardiologists together with the surgeons, with radiologists, with the industry, and we decide on what the best procedure is for the patient based on all the procedures that we have and the problems that the patient has and how we're going to solve them. We get into a room and we talk about all of that together. We go through all of the imaging and things like that, and we arrive at a plan that both surgery and cardiology feel is the best options for the patients, and then we proceed with that.
And that way there's no accusations that it's, just surgeons wanting to do surgery or just interventional cardiologists pushing patients towards their procedures. That way you're sure that based on the patient's situation, it's what's best for them.
Correct. Yeah, and it's great because everybody gets a chance to speak. Everybody gets a chance to say, my procedure is better or worse, or these are the complications that occur. This is the concerns we have. And when we're done with it, we all arrive at a single plan that we like, and that we're all we all feel is best for the patient.
Now, when we're talking specifically about minimally invasive cardiac surgery and the program that you have developed here, that is different from what the interventional cardiologists are doing. So can you explain exactly what we're saying when we say minimally invasive mitral valve surgery?
So there's a lot of iterations of minimally invasive.
Right.
When a cardiologist will tell you minimally invasive, they're usually referring to structural heart type of stuff. If they're going to be the people that are going to do it. And that's usually done transcatheter. So it goes through the vein or through the artery, and the procedure is done within the vascular system. With minimally invasive cardiac surgery, it's still an open heart surgery. It's not opening the chest. We do it through the side, through the rib space, but it's still an open heart. You still have to go on the heart-lung machine. We still have to stop the heart. The morbidities and associated with the procedures are a lot alike to the open procedures. There are some advantages to minimally invasive that we can get into in a little bit, but minimally invasive cardiac surgery is still cardiac surgery. So when patients come in to see me, a lot of times it's like, I'm not having open heart, I'm just having minimally invasive. Well, it's still the same operation on the inside. So we still are opening the heart and still operating on the valves, and the heart is still stopped, but they are not having the traditional sternotomy incision that they would get.
And we'll back it up even a little bit further. For those who don't know, can you start by just from the beginning, what is the mitral valve and why is it so important and to heart health as a whole?
Yeah, so the mitral valve's job is to prevent blood flow. All the valves in the heart is to prevent blood flow from going in the wrong direction.
Okay.
So a valve, you think of a valve as it's just a one-way valve. It allows fluid, or blood in this case, to flow forward but not to flow backwards. There's two problems that can happen with the mitral valve. One is that it can leak. The other is that it can be stenotic or too narrowed. So either the leaflets don't open well enough or they don't close well enough. And there's different reasons for each of those things. But if you start to have a problem with the mitral valve, it first starts with, could be palpitations, it could be atrial fibrillation, it could be shortness of breath when you exert yourself, and then that starts to become worse and worse over time. And if the mitral valve is leaking or it's blocked, it puts a lot of pressure in the bloodstream that goes to the lungs, and that's really the essential problem, is that you get too high a blood pressure inside the lungs, and then you start to get heart failure as a result of that.
So if it's going to be addressed, and a surgeon like yourself is going to take the minimally invasive approach to improving the mitral valve, how is this approach different from traditional open heart surgery as far as risks and benefits that you mentioned before?
So with traditional open heart surgery, it's an 8 to 12 inch incision in the front of your chest. We divide the breastbone and then we go on the heart-lung machine. It's about a 4-hour operation, usually in the hospital about 4 days or 5 days. And it takes about 8 to 12 weeks to recover from the operation. It takes just 6 weeks alone to heal the sternum. The sternum is a bone, and just like a broken arm or leg, it takes 6 weeks for the bone to heal. But the whole recovery period is about 8 to 12 weeks. And the risks are bleeding and infection and stroke and heart attack, kidney failure. These are risks of minimally invasive as well. And people aren't necessarily getting out of the hospital any sooner with minimally invasive, but the advantage of minimally invasive is that the recovery time, instead of 8 to 12 weeks, is about 2 to 4 weeks. So that's really the benefit. The other benefits can be shorter hospital stays in some instances. Typically, the younger people can get out sooner. The elderly people take a little bit longer just to recover and stuff like that, to go to rehab and stuff. But the main advantage is the recovery time. Also less blood loss, because I'm not opening the sternum, and the sternum in it of itself will bleed. So the blood loss is less, and so the transfusion rate is less.
How does the minimally invasive approach differ from the catheter-based approach that you were talking about before with structural heart for repair and replacement? Who's best suited for what procedure? How do you guys decide in those open heart team meetings?
So that's why we have the team meetings.
Yeah.
It can become a little complicated on how we decide on what to do, but in general, it has to do with age. It has to do with the particular valve that you're talking about, the durability, how long we think the valve that we're implanting is going to last, or the repair that we're doing is going to last. And our idea is to get somebody to 100 years old. And how are we going to do that? How are we going to manage the lifetime management of this valve, knowing that mechanical valves will last forever, but you have to be on a blood thinner, and people don't have obvious reasons, either have contraindications to blood thinners or don't want to be on blood thinners, or end up on blood thinners and they have bleeding complications of the blood thinners themselves. So the other option is tissue valves, and tissue valves are good because you don't have to necessarily be on a blood thinner, but they don't last forever. Depending on the valve and the location that you put them in, whether it's in the mitral position or the aortic position, they will last either longer or shorter, but generally you get about 10 to 20 years out of a valve. And that's a big gap, but it depends on age, it depends on your heart function, it depends on a lot of things. But I tell patients somewhere in average is about 10 to 15 years for a valve. So if a patient is young and they get a tissue valve, what are you going to do the next time around? And so we use the surgical platform along with the catheter-based platforms to kind of plan out a lifetime of hopefully without anticoagulation, without the need of blood thinners. We choose which procedure is being done based on the comorbidities of the patient, the age of the patient, the valve that we're going to implant. And that's how we make our decisions.
So who is the better patient for the minimally invasive approach?
So typically, we're seeing the younger patients who we feel will need either another operation or another procedure down the line. We're also seeing the patients that are referred for mitral valve repair. So typically, those patients are a younger group than those that are getting catheter-based. But we operate on people, into their 80s all the time, and it really has to do with what their perceived long-term survival is going to be. You have some people that are in their mid-80s that might live only a couple of years. You have other people in their 80s that look like they're going to live another 20 years. So
Yes.
It just depends on where they're at in their life and what other medical problems they have, and that's how we kind of choose. Mitral valve repair is usually in many instances superior to replacement. So we always look at repair first to see if people are candidates for repair. And then we look at the different options. Is it a surgical option? Is it a catheter-based option? We'll go from there.
Are the long-term outcomes of the minimally invasive approach as effective as the open surgical approach when it comes to your mitral valves?
So the minimally invasive approach, the morbidities and mortality associated with minimally invasive is the same as the open approach. Our operative times are the same, if not sometimes in many cases quicker, less blood, need for blood transfusions, and return to activities of daily life sooner are really the major improvements.
What are some of the most common concerns patients address with you before their minimally invasive procedure, and how do you address those?
So a lot of it is explaining the procedure, having them know that this is still an open heart surgery, managing their expectations with that. Just because it's minimally invasive doesn't mean that it's a small operation. The incisions are small, but the operation inside is big. And managing their expectations on discharge and going home, knowing that this is a minimally invasive option or minimally invasive surgery, and that their incisions are going to be smaller and their recovery time is going to be quicker, and making sure that they know that we're going to push them and we're going to get them back to doing the things they were doing sooner because they don't have that sternum to heal.
So you were talking before about the surgical valves. Does that mean that you can do replacement of the mitral valve and repair through the minimally invasive approach?
Yeah. So we can do mitral replacement, mitral repair, aortic valve replacement. We can do tricuspid valve surgeries. I can remove tumors from the heart. We can do arrhythmia surgeries like ablations, put clips on left atrial appendage. So it's a very versatile procedure. The only thing that we really don't do is bypass surgery through the minimally invasive incision, because typically the patients that need bypass, we need to get to all the areas of the heart, and you can't do it through a small incision on the side.
How does this surgery typically impact your patient's quality of life as a whole?
So they get back to their activities of daily life sooner, and that's really the message of minimally invasive. If you think about a sternotomy incision, 8 to 12 inches, it's a bone, just like if you broke your arm, you'd have to be in a cast for 6 weeks. We can't cast the sternum, so we rely on the patients to just treat it nicely and not do anything that's going to pull it apart or put pressure on it and things like that. With minimally invasive, we do it between the ribs, so there's really no bone to heal. And so people are limited by discomfort a little bit, but once the discomfort resolves, they go and do whatever they want to do. And I tell people that there's really no restrictions other than submerging it underwater, like in a pool or a bathtub. They can get it wet, they can shower. I just don't want it underneath the water until it completely heals and the scabs fall off. Other than that, I tell patients they can go home the day they get home and play tennis. They're not going to want to, but it's possible if they do.
Right.
So we get people back to playing golf, playing tennis, playing pickleball in a couple of weeks. We've had people running marathons at a month. We've had people doing, jet skiing and skiing, and snow skiing and jumping. I've even had a patient that did that jumped out of a plane and did a parachuting because the two of them always wanted to do that, and that was after their surgery. That's what they wanted to do. So
wow. I'd be home in bed, but okay. How important is the experience and expertise of the team when performing minimally invasive procedures like this?
So the OR team is essential because when you're doing these procedures, it's done through a 3-inch incision. So people in the room, except for the surgeon, really can't see what's going on inside. So I wear a camera on my head so people can see inside, but they have to know the steps of the procedure. They have to know what's happening next, because it's hard for me to look away and ask for instruments. If they know the procedure and know what the steps are next, I can still focus on what I'm doing, and I can hold out my hand, get the instruments that I need, and continue going. In the open cases, it's different because the other people in the room, they can actually look in and see the steps and see where you're at next. With the minimally invasive, it becomes a challenge in that way. But we have such a cohesive team that has been doing this so long. And the steps of the procedure, I try to make it as similar to the open procedure so that everybody is on board, knows what to do, whether it is the open or the closed procedure.
How important for a patient is it to go to a high volume center, to go to a place that has the heart team approach like Sarasota Memorial?
So when it comes to volume, if you go to a center that's doing a low volume, the surgeon isn't doing a lot, the team isn't seeing a lot, and therefore the procedures take longer, they have more complications. Patients may be told that they're not candidates for minimally invasive because the surgeon may be a little timid to do it, which is that's a good thing. If they're not doing it a lot, they really shouldn't. And so, just like I explained in the beginning, the more you do, the better you get, the more things you can do, you can expand the procedures that you can do and everything else. So, if you're doing 1 or 2 a month, you're never going to get that volume. You're never going to get good at it and efficient. I should say not good, but efficient at it.
Right.
When you're doing 4 a week, you get very efficient at it, and the team gets efficient, and then you can expand your repertoire of things that you can do through that same incision.
What advice would you give to someone who's been diagnosed with, whether it be mitral valve disease or any other of the heart conditions we've discussed here, and feels anxious about trying to figure out the best option or what their options are?
So I say, do your research. Like that seems to be the buzzword these days, is do your research, but also know your surgeon, know your cardiologist, know the people that are referring you, because a lot of times you'll see a doctor, they'll refer you to another doctor, and then they'll refer you to a third doctor, and you're just going on, their word, which is important, absolutely is important, who you get referred to. But then you need to go on your own and see, what is this person really doing? Is this person as good as they say they are? Are they doing as much volume as I think they're doing? Asking these questions, asking about outcomes, asking about when was the last time you did a minimally invasive case? How many are you doing a month? How are your outcomes? Those are all reasonable questions, and any surgeon that won't answer those questions, I wouldn't go to.
We've addressed a number of different things, and we appreciate you taking the time. Is there anything else you want to add?
I just want to say that our program here has been growing over the last 13 years. We continue every year to expand our services and that we have for heart surgery and for catheter-based options. I think we work very well with our cardiologists, and the heart team approach has been essential to all of this. And we have a tremendous support from the administration, which is important too, because we're able to get the things that we need in order to do the jobs that we need to do. So Sarasota Memorial is a wonderful system. It's a wonderful hospital. I love working here. This is where I would bring my family and my friends. And I think that it's going to continue to get better. It's going to continue to grow. And the heart program is going to continue to expand.
Dr. Hofberger, thank you so much for joining us. And if you liked this episode of HealthCasts, please like and comment, and visit smh.com/podcast to listen to more experts like Dr. Hofberger talking about the health issues which matter to you. Have a great day.